GluCare is a fully integrated, holistic approach to the management of chronic disease, specifically metabolic syndrome. And within that, diabetes and prediabetes. So rewind back to 2013. I was in the middle of starting my last business, and I get a call from an old buddy of mine who has his own idea of a startup that he wants to build. Kind of a wild idea. He wanted to re-architect the computer chip. Why? Because at the time, no one was really talking about all the buzzwords that we talk about today: machine learning, data science, AI. Back then, it was the remit and domain of a very select group of individuals and institutions that had access to the computational horsepower to do large-scale analytics. In that journey, he and I started to explore the intersection of the domains of data science and healthcare. I was building a healthcare business, traditional, old-school bricks and mortar business, and he was building, quite literally, the world's most advanced chip architecture and software to drive these analytics. And in that exploration, at that intersection of data science and healthcare, we started exploring what it means to use data, what it means to derive information and insights out of that data, and what it means to make that data useful and actionable. Have you ever gone to your physician and said, "Hey doc, can you do something with my sleep data from my wearable device?" Or, "I've been spending a lot of time logging my food in this app. What can you tell me about what I've logged as data here?" The response will be, "Oh my goodness, sorry. I don't have time for that. It's just too much data. It's too fragmented in too many silos." Physicians and care team members today are time-starved, under a lot of pressure and stress, and simply don't have the bandwidth or the capability to make sense of all the data. There's already too much data. So this kind of a data revolution has happened already once before. There was a time in the 1800s when surgeons used to cut people open blind. And when I say blind, I mean based on their own AI. After years and years of apprenticeship and mentorship and hours in the OR alongside a more experienced surgeon to understand the normative band of what the anatomy of the human is. And so they would cut people open without imaging. But in 1895, the X-ray was invented. In 1971, the CAT scan was invented. 1977, the MRI was. And an entirely new field in medicine emerged called radiology. Radiologists studied the same stuff I studied in medical school: anatomy, physiology, biochemistry. But their only job is to take this new data and interpret it with actionable insights for the rest of the healthcare ecosystem. And so you have a new library of data produced by a new category of hardware. But it's just a bunch of ones and zeros, right? And a new profession within medicine, a new domain with the sole function to interpret that data and make it useful. So that's already happened once in medicine. And it's happening again now, but with IoT devices and other ways of connecting to patients, wearables, CGMs, and a plethora of other pieces of hardware using different modalities to create new forms of data. But what are we doing with that data? How hard is it to aggregate it? How hard is it to harmonize it? How hard is it to derive actionable insights from it? Pretty hard. There aren't really many people out there that have figured out how to do that repeatably and at scale. Now let's think about the root cause of diabetes and prediabetes and why today we are where we are. In the last half century, in addition to all the innovation around imaging technology, we've evolved as humans on every other dimension related to healthcare. We've improved our drugs, pharmacological innovation. We've improved our medical devices. We've improved medical education. We've improved access to care. We've improved healthcare financing, insurance, which also drives access. We've improved healthcare regulations and oversight. Every possible dimension of healthcare as society on almost every corner of the earth has gotten better, not worse. So why is it that today, also in almost every corner of society, are we as humans fatter and more diabetic than we've ever been in human history, and getting worse? It's not getting better. We're not even plateauing. It's getting worse. And if I ask that question of 100 people, 99 of them will give me a version of the same answer. Patients aren't eating well. Well, they won't say patients. People aren't eating well. People aren't exercising. People are sedentary. The quality of our food is bad. X, Y, and Z. Lifestyle, choices, behavior. That's not wrong. That is not wrong. It's a correct answer, but it's not fully correct. Diabetes is partially a disease of genetic predisposition, but mostly a disease of an aggregation of choices and behaviors that manifest that underlying genetic predisposition. But do patients actually have agency over their own health in the way that 99 out of 100 people ascribe agency to them? I would argue no. When you're sitting at the table and someone serves you a beautiful, fresh out of the oven piece of chocolate cake, and it's steaming, and the odor of it is wafting into your nostrils, and you can taste it. Now, you're just listening to me through a video, and my words have just elicited a neurotransmitter response in your brain. Your mouth is probably already watering. There's no cake in front of you. I've just described it, assuming you like chocolate cake. Our brains are really good at grasping the immediacy of satisfaction in the moment. But if I asked you, and this is now using a financial construct, in that moment that you're about to eat that piece of cake and really extract the maximum satisfaction out of every bite, if I ask you in that moment, can you tell me what the net present value is of all the future risk associated with that behavior, with eating that piece of cake? You wouldn't be able to do that math. We're just not wired that way. It's very hard for us as humans to collapse the timelines. And so what happens? 1,000 micro behaviors back to back, we over-index on the immediate and we under-index on the long term. And so what happens is that we make a lot of bad choices. And in aggregate, those choices lead to things like metabolic disease. Why does that happen? Is it the patient's fault? Do they have agency? Do they have the information to make the right decision? And in many cases, they don't. And I would argue, along with 1 out of the 100 people that we asked this question, that agency lies with the healthcare system, with the providers, with the doctors, the nurses, everybody engaging with that patient in order to help them on their journey. Agency also lies with the payers, the insurance companies, and the regulators that construct the incentives in order to get the providers to behave in the way to maximize outcome on the patients. Diabetes is such a big problem. 500 million people worldwide suffer from the disease, and that's only going to get worse. How do you serve a large chunk of that population? Can you serve a large chunk of that population through digital-only means? I'm not sure. Certain segment of the population, educated, affluent, access to technology, time-starved, who want to save time by using a virtual platform. There is a segment of the population that is naturally more amenable to a digital-only, virtual-only solution. But there is a very large segment of the population that needs the human touch, that needs to interact with a physician. Doctors are incentivized on throughput, top-line KPI metrics. How many patients can you see a day? So what happens? Patient visits become quite short. What happens in that 10-minute visit that you have with your GP? That doctor is usually spending about 30 seconds maybe looking at you in your eyes and making human contact, but at about 9.5 minutes over here, looking at their computer screen on their desk, tapping away into the EMR, trying to record whatever it is that you're saying. There is no chance for real human connection and trust that needs to be established if we all agree that metabolic disease is primarily a behavioral issue. Let's talk about the desk and the computer that's distracting the physician. Why does it exist? Do we need it? What purpose does it serve other than an actual physical barrier between the patient and the physician? Why is the physician wearing a costume? A suit, a tie, the lab coat, the embroidered name with the MD at the end, the degree on the wall. Is all of that necessary? It's not Halloween. Why are we dressing up? So it's not just about the technology and the AI and the machine learning tools and the way you pull it all together. It's also about first principles on a fundamental basis. When you think about the ingredients that make up the interaction with the patient and their experience. So what I've just described to you is kind of a flawed human interaction. Let's talk about the data that's transacted in that human interaction, which is already flawed. If you're a diabetic or a pre-diabetic, let's say you're a diabetic, you're seeing your physician once a quarter, according to American Diabetes Association guidelines. And every single visit, the doctor is going to ask you the same thing. Are you eating well? Are you taking your medications? Have you been exercising? Have you reduced your alcohol consumption? Did you stop smoking? Et cetera, et cetera, et cetera. And they're furiously typing away on their computer the responses to those questions. Are you telling the truth? Most likely not. Many patients, not out of an inherent, character flaw, are they not telling the truth, but we are embarrassed about our inability to take care of our own health. And so we don't always tell the truth when we're in front of our physician in that moment. But even if we were the most truthful human on earth, in that moment, our power of recollection to take 4 months of history and collapse it into a cogent insight to give to our physician, that's very difficult. It's difficult to be honest and accurate with that much information in that short of a period of time, in that snapshot of time. And herein lies the problem. Healthcare today, in most places, is architected as symptomatic, episodic, and therapeutic. I.e., come see me when you have a problem. We'll talk about your problem. I'll attempt to address your problem, and then I'll send you home, sometimes with a prescription, sometimes not. And maybe I'll see you in 6 months, or a year, or maybe I'll just see you when the problem comes back, or when you have a different problem. In that transactional, reactionary model of care, which is the standard of care everywhere, it is impossible to change the course of this disease. You simply cannot. Because by the time the patient who is diabetic or pre-diabetic shows up in your clinic with a complaint, it's already too late. The damage has been done. And someone who is pre-diabetic, who then advances to become fully diabetic, that individual, on an incremental basis over their lifetime, costs $500,000 more than someone who's not diabetic. So the costs over the lifetime are enormous, and we bear that cost somewhere as society. In the United States and in other countries where it's insurance-driven, insurance company covers the cost, but ultimately it's the employer that pays the bills. And ultimately that's part of the benefit package of the employee. We all bear that burden. It's just a question of timeline. So how do you fix that? It's a big sort of question to unpack. And that's what we've tried to tackle at GluCare. From a first principles basis, we looked at every possible step in the pathway, every possible interaction, and eliminated those things that were unnecessary, that didn't drive outcomes. Everything that we do is on a single North Star. Does it contribute to behavioral change in a sustainable way? Because if you can engender behavior change, you will engender better outcomes. I love this notion of earning the right to win in everything that we do. And when my co-founder and I started thinking about building this platform, we scanned the market because there's a lot of really smart people looking at the very same issues and the very same problems across multiple geographies. Most of the attention to date, and this was back about 3 years ago, was spent on building purely digital platforms, digital therapeutics, DTX. And we thought deeply about whether or not that actually gave anyone the right to win at scale. And so part of our thesis right out of the starting gates was, how do we merge the human with the clinical platform and the technology platform into one symbiotic, holistic platform? We believe that that would earn us the right to win, measured by the scale of our outcomes and our ability to impact the overall costs. So, what is GluCare? GluCare is multifaceted. There is a component of GluCare which is physical. We have a physical clinic. It's beautiful, 10,000 square feet. It has a lab, it has a pharmacy, it sees patients, it has doctors and nurses and the whole care team. We have a technology component, which is an amalgamation of hardware, wearable devices, other IoT connected devices, where we integrate and absorb massive amounts of data on a continuous basis and use that data to create information and ultimately actionable insights for our patients and our care team. And we also are able to interact and engage with our patients continuously. At GluCare, our patients never leave us. When they come into the clinic, they get their labs done. Results are typically on the spot in 30 minutes and uploaded into the cloud. By the time they see their endocrinologist after a short wait in the coffee shop, they've already got their results. And the doctor sits down with no desk, wearing a polo shirt just like this and a pair of sneakers, sitting at eye level in a coffee shop-like environment, walks them through their data and educates them on their disease. No distractions. After the visit with the physician, the patient then goes and visits a dietitian, a nutritionist, a diabetes educator, and a coach. Those care team members you typically would not see in other contexts. Why? Because providers are not incentivized to do that work because they don't get paid for it. Insurance companies today, in most places, will not cover a nutritionist or a dietitian or a health coach. And so people don't do it. We do, because we believe that having that is an integral, inseparable part of the process, and it helps us earn the right to win. What is the right to win for us? It's the pursuit of the best possible outcome at the lowest possible unit cost. So a patient will run through our platform, and a visit at GluCare will probably take a couple of hours. They'll do the traditional lab test, they'll see the endocrinologist, and they'll spend time with the care team. They'll also do thyroid ultrasound, liver ultrasound, EKG, have a retinal scan. Most of those not powered by humans, powered by AI. This technology already exists. We've aggregated that into a single platform. But when they leave, they actually never leave. They continuously stream data back to our care team. 24 hours a day. And it's a ton of information, which is why no human can sit on top of it and study it and interpret it real time. That's where your algos come in play. That's where your AI and your ML comes in. So you have the machine now observing, tracking, and flagging issues of interest or moments when the care team itself needs to engage with the patient. But most importantly, we use it to drive engagement and behavior change. And so part of what we do as well is make sense of it in a way that allows the clinicians to derive actionable insights efficiently, so that they don't have to go and pull data from the Apple Health Kit or from this wearables SDK or from another layer of IoT connected devices. We do that heavy lifting. Our algos in the cloud and our layer of architecture serves up the insights efficiently, not only for the benefit of the clinician, but also for the benefit of the patient. And as a patient stays with us longer, they derive incredible benefit from the transparency around their own data and the connections that we're able to make. So the existing digital therapeutic platforms that are out there, and there are many, are great, and they've achieved phenomenal things. The best-in-class digital therapeutics platforms in the United States have earned a 1 percentage point reduction in hemoglobin A1C. Doesn't sound like a lot, but it is. A 1% reduction in hemoglobin A1C correlates to roughly a 20 to 25% reduction in comorbidities, 20 to 25% reduction in fatalities related to diabetes, 40% reduction in cardiovascular risk, but most interestingly, a 13% reduction in diabetes-related healthcare costs. It's a butterfly effect. 1% translates into pretty big impact across the board. We generated double that in half the time. 2.1% reduction in hemoglobin A1C in just 90 days. All the while, reducing the body weight of our patients by 5%, reducing LDL by about 20 to 25%, uric acid by about the same amount, and in parallel, reducing the overall pharmacological load of our patients. They're just taking less drugs while under our care. But most interestingly, and we followed the data, we've asked each of the insurance companies with whom we work, have any of our patients, while under our care, transacted with other providers for the same CPT codes? i.e., are they still shopping around? Are they still overutilizing healthcare resources? 0. At the time that we asked, not a single patient had gone anywhere else after having become a patient at GluCare, which for us is phenomenally fulfilling. Now, the costing piece is also interesting. If you're a virtual platform, generally speaking, you are a layer on top of an already existing legacy infrastructure without the ability to directly pull levers on cost and benefit. That isn't going to get you all the way when it comes to cost containment and deriving efficiency gains out of a platform. That was another reason, in addition to having to touch the patient, that was another reason why we thought our platform needed to be fully integrated vertically. Because we needed to be able to pull the levers on costs, on prescriptions, and on behavior at a granular level. But the real innovation will come in how we think about paying for health, not health care. Providers in the future should be paid when someone's healthy. Take a pre-diabetic. Let's not pay providers when the patient is sick. Let's pay them only when they make that patient better. And let's keep paying them as long as they keep that patient well and not pre-diabetic. For the employer, there's a very strong story around prediabetes prevention and reversal. And we have an extremely high success rate in prediabetes reversal. Take me as an example. About 8 months ago, it's middle of COVID, and I've been working hard for a number of years, building businesses and spending time with my family, and certain things fell by the wayside, i.e. exercise. And I also love to eat. My family is a whole bunch of foodies. And slowly, my weight went up, my cholesterol went up, my uric acid went up, I had a fatty liver, and in May of last year, I officially became pre-diabetic. Not a good look for someone who had just opened a diabetes center. But my fasting blood sugar was in the pre-diabetes range, as was my wife's. And my BMI was about 29.2. I was 89 kgs. So I, the next day, became a patient in my own clinic, on my own platform. And within 3 months, I lost about 17 kilos, completely reversed my high cholesterol and my hyperuricemia, and completely reversed the prediabetes. Gone. In addition to that, I was 3 times more effective on the soccer pitch or the football pitch, depending on what continent you're on. 0 downtime recovery after, no aches and pains, didn't have to take ibuprofen for my joints. I was a new man. I was half the man I used to be, physically. But this holistic approach really does work. So how can we help you? We expand through partnership. Our model is built to be modular, to be flexible. There's a very clear value proposition and narrative for every single stakeholder that we speak to. What's great about our platform is how flexible and modular it is. We can flex it and transform it to fit a large variety of payer contexts, provider contexts, and regulator contexts. But the North Star remains the same. This is not about expanding a technology or a brand or a logo on the wall. What this is really about is replicating superiority of outcomes at scale. Thank you for listening to our story.